how to address a common complaint. Thank you. Thanks for being with us.
Hi, everyone. Thank you for having me. All right, so it is a common complaint, and so that's why I thought it would be an interesting topic to present. There are a lot of different things that people hear presentations on with respect to endocrinology, and I don't often hear presentations on hirsutism. So I thought that that might be something of note because your patients will be coming in with hirsutism. They may be on therapies for hirsutism. They may be seeking outside resources for hirsutism that have some complications associated with them. And so just a little bit of knowledge about what you might see with your patients might be helpful. So our learning objectives are listed here today. I think that our audience does know what hirsutism is, but we're going to look at some things with respect to that. Review of the hair cycle. Any good endocrine lecture either has a feedback loop or a picture of the steroid pathway. So I do have the steroid pathway for you in this one. Tomorrow is feedback loop, so stay tuned. We'll look at the scoring system that is used, some causes, and then how to work up a patient. And as I said, the treatment. And throughout this presentation, I also hope to address the psychological impact of hirsutism because that is very important to consider in your patients as well, and then looking at some treatment options. The focus of this presentation is going to be on premenopausal women. And when I refer to women in this presentation, I am referring to women and people who are assigned female at birth. So what is the definition? It is excessive hair growth, and specifically, though, it is terminal hair growth and a male pattern distribution in a woman. Okay, so how common is it? It is very, very common. So 5 to 10% of women of reproductive age. So that is a large part of the population that you'll be seeing. And is it serious? So is it serious enough to discuss? So it is a greater likelihood, thankfully, from a medical standpoint, like from our standpoint, that generally it is not as medically serious as some other things that we see. Although we have to be attuned to the fact that it could represent something that is very serious, some underlying medical condition that we do have to address. And then the other thing, like I said, though, the emotional impact can be very serious for the patients. So is it endocrine mediated? Well, I am here today from an endocrine standpoint. It is one of the most common endocrine disorders, and it is the main manifestation in patients who do have PCOS. I think that people often think that PCOS is the only cause of hirsutism, so that's why just shedding some light on some of the other causes today. But that's a logical conclusion that people have because 70 to 80% of people with PCOS do develop hirsutism. So it makes sense that people have that link and association. And that's an important association to have as well because you do want to recognize PCOS and be able to treat PCOS, both from the psychologic as well as the underlying medical impact and, the future morbidity and mortality that's associated with PCOS. So how do we manage it? Well, we look for what is causing it and treat it if there is an underlying condition. And then we listen to the patient in development of our treatment plan because you'll see at the end, we have a lot of different treatments that we could use. And so we want to target that for what the patient's goals are. As I said, this talk is talking in the premenopausal age group. So because of that, there is that concern about fertility. And when I say concern, what I mean is the patient trying to become pregnant or does the patient desire pregnancy? And then what is our pharmacotherapy? Because some of them are teratogenic. So we have to be very thoughtful about what we are doing and what the patient's goals are. So hair. We are born with a lot of hair follicles. And 80,000 to 150,000 of these are on our scalp. Interestingly, the number does not change over our lifetime, but the follicle size and the type of hair can change. It's a little fun hair facts. So how does the hair grow? And the importance of this slide is because this is the part about if you do use pharmacotherapy, you have to wait to see the effect. Because the anagen phase is the most prolonged phase, the growing phase. And so it can take approximately 4 months for things like facial hair. So because of that, if a patient is on therapy, then it may take up to like 6 months for the patient to notice a change as a result of the medication. So you have to have that knowledge in the back of your mind about how hair grows so that you would be able to tell the patient, because otherwise the patient might be appropriately frustrated if they haven't noticed any change or improvement in 1 month, but you didn't tell them that it could take much longer. You don't necessarily, have to draw them the phases of hair growth, but we have to have that appreciation so that we can have that, give that information to our patient, so that that can help them. So you can see that the other, sorry, I didn't realize my animation wasn't initially up, but it was just the percentages of the hair on the scalp that's in those phases. So this slide is an important slide from the principle that, androgen is going to, have an effect on the terminal hair follicle. But what's in this orange box is kind of the take-home point of this slide is that even though we know that the plasma androgens are going to affect that terminal hair follicle, a patient's hirsutism score actually does not necessarily correlate with the androgen level. So some patients are very sensitive to androgen, so they can have a normal lab value in the reference range for androgens, but demonstrate a sensitivity to those androgens and have a manifestation of hirsutism. So it's not always, you don't see that as, something that tracks with each other necessarily. So it's not always just the level of androgen, it's how sensitive is one individual's receptor to that androgen. So, of course, the hormones that are involved are androgens. I keep mentioning them. There are the primary regulators of hair growth. So what are we looking at? Testosterone and DHT, the dihydrotestosterone, which probably from here I will say DHT. And then as far as DHEA sulfate and the androstenedione. That one is still very hard for me after all these years. So what happens with our androgens, as I said, is they bind to the hair follicles. And what the result is that vellus hair, which is that thin, fine hair, gets changed into the terminal hair, that coarse black hair, in the androgen sensitive areas of the body. So, and we always are looking at, with any hormones, what happens when the hormones are too high, what happens when the hormones are too low, and sort of where is that space where the hormones are normal and the patient's sensitivity is normal, so that we always look at things like that, of course, in endocrine to see. So we do obviously have hormonal effects on our follicles. And as I said, some people will have too much androgen and some people will have too much sensitivity and some people will have both. So here it is, as promised, but we won't go into great detail with it. But the point of it and purposely putting it in is it does matter. It does mean something for the different potential causes of hyperandrogenism in patients. So, when necessary, to go back to this pathway and to look at the different enzymes and measure different things in different patients to follow the process along. So where do we get androgens from in the female patient? It could be the adrenal glands, and it could be from the ovaries as well. So that's the thing. And the reason for bringing this up and reminding everybody about where it comes from is because it does matter if you do see somebody who becomes markedly androgenic, or and we'll talk about that in some subsequent slides where you're concerned about a mass. And so you have to think about ovaries and you have to think about adrenal glands. And then it's important too, because it's sort of where is the person in their reproductive life cycle as well, because depending on the onset of hirsutism, that gives you some clinical clues too, because if it's something, that is, with puberty and correlates with the onset of menses, and the patient also has irregular menses, and then you're starting to think of that PCOS picture, versus if the patient, had regular menses and they're farther along in their reproductive cycle and all of a sudden manifest with virilizing features. That would make you think more of a mass. So that's why it's important to, think about those things and kind of understand these pathways. Oh, look, it does have feedback. Okay, this one does. I do have an access. I got both in the same presentation. Okay, so looking at this, once again is, we are under control from the pituitary for both the ovaries and the adrenals, and then having those effects on the peripheral tissues in the patients. So there are other hormones involved. We're not going to go into great detail in general in this presentation today about all the different hormones, just at this brief overview and focusing on, refreshing our memories about androgens. But estrogen, progesterone, and thyroid hormone can affect hair growth as well. So the scoring system, if you haven't seen this scoring system before, this is the Ferriman-Galway Hirsutism scoring system. And what they did is they looked at each of these 9 body areas that are most sensitive to androgen, and how to score. 0 is no hair, and 4 is frankly virile. And I will say, and came up with this score. I will say that when I started in training, I know that I was in some places where the recommendation was to have the hirsute patient come to the office without doing any hair removal for us to do this score. And thankfully, in my opinion, that has changed over the years, because, patients are very sensitive to this, or could be, I should say, because not every patient is. So it does depend on the patient. But as far as it goes, if the patient, asking a patient, to come to your office, sit in the waiting room, allow hair to grow in visible spaces so that you can do this score, I think that we can have, more understanding, and we can still see. If you have seen a patient with hirsutism before who has maybe shaved or plucked, or you can still, visualize and you can appreciate where the hair has been without asking the patient to come in hirsute just for you to be able to do the score. I think that as clinicians, we have a greater ability to just work with our patient from that perspective, and make for a more welcoming office visit for our patients. So with respect to this, how do we interpret it? So, it's not an exact number in that sense, like low number is mild, and then high number is severe. And then from the physician's perspective, we have to remember that the number can depend upon the patient's ethnicity. So we have to sort of scale that in our minds depending on ethnicity. But from the patient's perspective, that number means nothing. Okay, the patient determines the severity for themselves. And it is important for us to listen to that. So to help guide our treatment for that. So, and remembering that the score does not correlate with the androgen level. So someone can have a higher score, but just maybe be very androgen sensitive. So you still want to treat the patient, even if the androgen level is normal, to treat the patient from that perspective. So there are androgen and non-androgen types of hirsutism. And so I know I just spent lots of time talking about the androgens, and that's because that is the most common thing that you will see as far as the cause, that 80% is due to that androgen excess. But as I have said repetitively, and there's a reason for that, you don't have to have elevated androgens to have hirsutism and that sensitivity. So just kind of driving home that point, because sometimes we get lost in our lab values. And so we have to think about that in connection with what we know about a disease process, and not just lean on a number as much. So it probably, well, maybe it does project. Okay. So I was gonna say, because it's so small, the green, so the green is the androgen secreting tumors. So thankfully, that is such a small piece of this pie of what causes hirsutism. And that's good, because androgen tumors, are not good. So from that perspective, that it's good that it has a lower frequency. That being said, I always say when I'm teaching students, if you're the patient that has it, the frequency doesn't matter, because it's 100% for you. So from that perspective, you do have to have this in your mind, as far as to be thoughtful, to make sure that you have thought about it, considered it, and ruled it out. because if you happen to meet that patient who is in that small percentage, they would do well having met you and you recognizing that in the patient. And then we're not going to talk today because and those are like individual talks in amongst themselves. And then the congenital adrenal hyperplasia is another cause. And then you can see like the biggest piece of this is the PCOS. The other thing is, these are other endocrinopathies that we do need to potentially exclude. Like I said, we have to take in the whole picture of the patient, but Cushing's syndrome, hyperprolactinemia, acromegaly, and thyroid dysfunction. So like I said, each of those, are their own toxin amongst themselves, but these are things that are kind of like running through the back of the brain with hirsutism. So the cause, it could be just the natural production of androgens. It could be something that is, from the adrenals in the form of congenital adrenal hyperplasia or tumor, the ovary in the form of PCOS or ovarian tumors, as I said, Cushing's syndrome, medications. And medications are interesting because not only do you have to get the patient's medication list, do you know who else's medication list you need for this one? Their partner. If their partner is on a topical testosterone therapy and the patient is in contact with someone's skin who, so that is something, usually, hopefully, there's education to the patient who is prescribed testosterone. If it's, in that format, so that is not shared, between people. But that is important to ask the patient about because, they may not think of that from that perspective. Idiopathic, we do always have that in medicine, right? That idiopathic, but what does idiopathic in this category would mean patients with normal menses and no clinical evidence of PCOS or other hyperandrogenic disorder. So that's what the idiopathic is so because you really have then like gone through that whole list and ruled those things out. So the idiot, now that it's kind of confusing though, because there is, you have to be careful what you say with your words. Well, we always have to be careful what we say with our words. But if you say idiopathic hyperandrogenism, that's where the patient does have elevated levels of androgen, but they have normal menses and normal ovarian morphology, so not PCOS. If you say idiopathic hirsutism, then everything, regular menses, normal androgen, and no underlying disorder. So just being careful, if you're reading something, to make sure you read the terms correctly. So I highlighted here, I bolded here rather, PCOS. And so I do have a very little bit of information of PCOS because like I said, that is a talk. And that's a talk that's often given, appropriately so, by gynecology as well as endocrinology. And we do tend to work together to manage patients with PCOS. It's an extremely common endocrinopathy. And so from the metabolic side of the world, handled a lot by endocrine and, and then with our partners in gynecology, depending on different hormonal therapies for the patient and patient's desires for reproduction and those kinds of things, working together. So there are criteria for the diagnosis of PCOS as well that are, oftentimes, discussed. And so the amenorrhea or oligomenorrhea and infertility is, a big criterion that you see. The clinical picture with hirsutism, acne, or any other biochemical evidence of hyperandrogenism. And then if you see the polycystic ovaries on ultrasound, so you're looking for 2 of the 3 of those. So you have to distinguish that from hypertrichosis. And I should have put a picture, I apologize, of hypertrichosis. If you have not seen that, it's that excess hair growth as well. It's not in a sexual hair pattern though, like the post-pubertal androgen sensitive places that people think of. It is it's the vellus hair. And you'd see that a lot of times on like forearms and the lower legs. And there's certain medications from that you might have recalled from days of pharmacology like phenytoin and cyclosporin that can be responsible for that. And it's not caused by excess androgens. So how do the patients present? I mean, this is something that's self-diagnosable. So the patient might present to you and complain about hirsutism. Or you may see the hirsutism. This is where you have to be careful. And this is where, sensitivity and all of the things that all of the skills that you have as a clinician, because you may see something and have a concern about it, but the patient does not. And so you have to broach the topic in a very sensitive, appropriate manner, because like I said, you're concerned then about a possible medical etiology underlying the hirsutism. So you would have some questions about their hair growth. But once again, they may not consider it excessive. And or you may see the patient not consider it excessive, and the patient perceives that as excessive. So that's why we work together in our conversations with our patients. So an increased likelihood of hirsutism if a patient has a family history. Certain ancestries have a higher likelihood of hirsutism, and then obesity, patients with obesity, you will see more hirsutism. So questions that we ask a lot of questions. Here are just a couple of things, the age of onset of the hirsutism. And as I said, that speed of progression, because if it is something that had sort of that insidious onset versus it wasn't there and now it is, that rapid onset always makes me think of tumor. Relationship to puberty, because PCOS, of course, its relationship to menstrual cycles and puberty, and then finding out questions about the history of the menstrual cycles. The severity. And once again, that one is under this list. You would want to ask severity for the patient perspective, but then when you're thinking about severity too, in this part of the decision, it's the severity to you would be as far as considering that possibility of an underlying tumor. From that perspective. And then the exogenous androgens on the set patients can take exogenous androgens too. And they may get them from someone else, and they may not tell you about them unless you ask about them. And I mentioned about the partners before. Specifically, changes in libido. When you're thinking about hyperandrogenism, you're thinking about increases in libido. And then you want to ask the patient in your history taking, if they have attempted to remove the hair, what the outcomes were. Because you're going to, if you're thinking about treatment, you don't want to give somebody or recommend a treatment that has been unsuccessful for the patient already. So that's not an efficient, good use of their office visit with you and their money for pharmacotherapy or whatever else. So finding out what they may have already done, and maybe they're happy with what they're doing too. So we don't need to add anything else to that if that's where if the patient is happy with that. And then family history as well. So like I said, if it's idiopathic or less serious forms will onset at puberty versus middle age to older women. I hate when they put those terms. I don't know what middle age is, and I'm very sensitive to this terminology, but I guess later in our reproductive cycle, concern for ovarian or adrenal tumors. So physical exam is still important. History is still important. Physical exam is still important. Because like I said, our labs and our images and stuff are not, I mean, certainly if you have an image and there is a tumor, that is going to give you a lot of information. I'm not saying that, but I just said our labs don't necessarily help us in some of these situations. We're still going to get them to see what's going on with the patient, but we're going to get them in the context of the information we already got from their history and from their physical exam. So we do look at parameters and looking at that with respect to obesity. We do look at their blood pressure, because thinking of other endocrinopathies, and an objective measurement of the hair quality and distribution. And as I said, I mean, you can still look at a patient and get a good perspective, like I said, without asking a patient to not remove hair. And then the rest of their skin is important too, as far as acne or oily skin or other patterns of hair loss. And then things like acanthosis nigricans, thinking about insulin resistance, things like stria bruising or thin skin, thinking of Cushing's. And like I said, tumors, you don't want to forget that, even though it was like such a small little wedge there. So if the patient has rapid virilization, then you are very concerned about that patient. And, unfortunately, like some of the adrenal tumors, after they're diagnosed, the patients, the morbidity associated with them is very high. So you just, because they are very fast. And so a lot of times too, when they're diagnosed, they're already very large. And so things like that. So you do want to be aware, even though it's a smaller piece of it. And then abdominal and pelvic exams, as appropriate based on what you've already gotten from history, what you've already gotten from the physical exam, as far as if you're thinking something is coming from the abdomen or pelvis with respect to the ovaries. So our diagnosis is clinical. So then why would we pursue a workup if it's a clinical diagnosis? Well, it's because, we want to make sure there's not something underlying that we need to treat as well. Because you can treat things concomitantly. So you can treat the PCOS, and sometimes some of our treatments for PCOS are going to also treat the hirsutism. So that's nice when they're paired with each other. And just making sure, like I said, there's not something else going on, any added medical risk, or thinking about any other of the disease processes that can cause hirsutism. So I mentioned these already, just because it made sense like in the previous slides too. But as I said, it is worth kind of the repetition of it just to remind us all, that rapid pace of development, rapid progression, or if you do start a patient on therapy and then they're not responding to therapy, and in addition to not responding, like progressing despite anti-androgen therapy, then you would be concerned from that perspective. If there are menstrual irregularities, then PCOS or idiopathic, and then weight history. So that a weight history is important too, because patients, there are, with PCOS, patients may have obesity as well as PCOS in that setting. So it is important though to find out sort of where that weight gain was and the speed of that weight gain, because you may be thinking about Cushing's syndrome if it's a rapid weight gain versus, a slow progression of weight gain associated with that. You really are only going to see that frank virilization, I think, and those androgen producing tumors, or something, I don't know if you guys have heard this term before, that ovarian hypothecosis. So in a patient greater than 30. So that's where you would see those typically. Okay, so workup. So endocrine, some labs would be involved, and some hormones would be involved. So we will test for elevated androgens, and that might help us indicate the source. It may not though, because, we talked about it as far as in the patient, it could come from the ovaries, or it could come from the adrenal glands. So we are detectives, and we put all the pieces of the puzzle together. And so we look at the testosterone. So you do, patients who have insulin resistance do have decreased sex hormone binding globulin, so their total testosterone might be lower. But the free T4, T4. I like thyroid too. That's tomorrow. I got ahead of myself. The free testosterone, that will be circulating around and active and binding. So if you, like I said, if it's very high, then your suspicion for tumor is there. If it's mildly elevated, thinking of a more benign, and I'm cautious with the word benign because like things like PCOS, are they benign? They do have their own morbidity and mortality associated with them, because, if there's metabolic syndrome associated with that, and then, what happens with that, with consequences for our heart and with diabetes. So it's not, from that perspective, you have to be thoughtful about that word benign use there. And then normal, as I said, it could just be that sensitivity that patients have. So the lab value could be normal, but their sensitivity could be higher. So, and then if you get that elevated testosterone, it's sort of like, okay, you've started, you have a piece of information, but now you don't know which gland it's coming from. So now you have to do more investigation. So then thinking about the DHEA sulfate, because when we look at that, that is going to be coming from the adrenal glands. So if that's going to be elevated too, then it's more likely adrenal. But if you get the DHEA sulfate and it's not elevated and just the testosterone is elevated, then you're thinking more likely ovary. So that's why I said, like, we're detectives. So we do one thing, we see what that result is, and then we do another, just like we do in all the other places in endocrine. It's not different there. So we do get the DHEA sulfate. It is because it's stored in the adrenal cortex, and it's what's circulating around, and it's what we do follow when we are getting our labs. So what else? It would depend on how the patient presented and what your running differential is based on the patient's story and the physical exam that you had done thus far, whether you needed a prolactin, whether you needed a TSH, whether you needed to screen for Cushing's or acromegaly. That would depend on, the information that you already had from their history and from their physical exam to guide you. So, typically the starting place then is going to be testosterone, 17-hydroxyprogesterone, and that goes back to steroid pathway slides, how to investigate for congenital adrenal hyperplasia and the most common cause of congenital adrenal hyperplasia, and then your DHEA sulfate, looking at the potential for an adrenal source. And then imaging would depend on the labs. I mean, you're not just going to get an ovarian ultrasound, CT or MRI of the adrenal glands in everybody, right? If you were suspecting PCOS, an ovarian ultrasound, or if you were suspecting testosterone is high and the patient had, more severe presentation of hirsutism, then you would be getting an ovarian ultrasound thinking of a tumor. And then the CT or MRI of the adrenal glands would be if you had the elevated testosterone, the elevated DHEA sulfate, and you were concerned based on their clinical presentation about the adrenal. So it's not that you get these on everybody. I think if anybody has ever come to any of my other talks, I always love to talk about incidentalomas. And so they are things that are incidentally found. And we grow things in our glands, and they may not be producing hormone. So you have to be very careful to not shotgun image things unless you know what you're doing as far as why you're doing it. We should always do that with anything we order. We shouldn't just order it. We should have a reason. But in endocrine, you want to prove something, biochemically, if you can, before you image, because then otherwise sometimes you'll have something and then you're like, but then the labs are normal. And so that's oftentimes oftentimes patients will end up with their local, very friendly endocrinologist. So when not to order labs, if you have a patient with normal menses who has, normal hirsutism score and unwanted local hair growth, and then there's based on how you've, already investigated the patient with your history and your physical exam, it doesn't appear as though from what you've put together that it is something that the labs are going to change your management, because it doesn't appear as though there's an underlying medical disorder. So this is really busy and does not project very well. But and we're not going to go through it today. Its purpose of being here, and these can always change as well, is guidelines. Endocrine also has a lot of guidelines, like every other specialty does as well. And they, by their societies, and they do update them. I have this one, and then I have this one. The second one is from the Endocrine Society. So my point of this is when you have a patient, and, I could argue, because my other presentations have guidelines too, is like with any endocrinopathy, I think the guidelines are helpful to see where you are in the algorithm with your patient, and to make sure that you have thought about all of the other pieces of the puzzle, and something isn't missing. Guidelines, of course, don't replace your clinical judgment, and guidelines don't speak to every individual patient either. So, but the importance of this is, like I said, just seeing kind of where you are in space and making sure that you have done due diligence for your patient, and you have uncovered every rock and thought about everything that was necessary for the particular patient. And it does help you based on what their lab values are and based on their presentation, keeping you like organized in your thought process. So as I mentioned at the very beginning, the psychological impact is real, and it can be very emotionally distressing for patients. It could be something that they're very distressed about, that they want to talk about, but they're embarrassed to bring up. They might be very self-conscious. It can lead to depression and anxiety in patients as well. So is treatment necessary? No, not from our perspective. if the patient doesn't have an underlying endocrine disorder. So if there's not a underlying medical disorder, then it's not necessary that it is treated. And then, as far as it goes, the patient important hirsutism though is, and I know, it's not a good lecture style to read from a slide, but this is such a good quote. Unwanted sexual hair growth of any degree that causes sufficient distress for women to seek additional treatment. So that is very important to keep into your mind, that this is like patient important, what is important to the patient, and having that balance with what we are seeing as well. So, not everybody, there are limitations, to that scoring system. Not everybody is familiar with the scoring system. As I said, cosmetic measures may interfere, but like I said, you can still use your clinical acumen and good history taking skills and get some more information. And then the patient's desire for treatment may not be proportionate to their score in either direction. So what do we have? So we have that we could treat the underlying endocrine disorder, and we could encourage the patient, if it was appropriate for that patient, weight loss. There are cosmetic treatments, and then there are systemic treatments as well. So it's very important, though, to find out what the patient's reproductive goals are, because that will, give us some information about which direction we should safely go for the patient. A lot of these things, though, are not separate, and they're not necessarily like in a stepwise fashion. These are things that are used in combination. And I think that it is important, as with treating anything, to set appropriate and realistic expectations, with the patient of the treatments and their successes, as well as I mentioned at the beginning, the timeline, so that they know what to think about and what to expect. And, to be able to communicate that to you if things are or are not successful for them. So, the treatment of the underlying endocrine disorder would be, relative to which endocrine disorder it was. And so, there's, full set of treatment options for PCOS, for Cushing's, and it depends on which Cushing's it is, and, all of those things. So it would depend on what the underlying disorder was. Weight loss is helpful for patients as well. So that is something that should be included regardless of the other things that you are doing. And then your patients oftentimes may already be employing cosmetic modalities, and they don't have to stop doing that. So that's why I said it's important to sort of, if you haven't heard of some of these things or realized actually how they work, I was just going to show a couple of the different things that are out there. And then systemic, the medications. So let's look at cosmetic. So these are things, and they go into the category of short-term and longer term. And I think, because I don't know why this is very small font. So I apologize for that. But it's, as far as thinking about it, the terminology associated with it. So, and it kind of speaks to some of my future slides, where it then talks about how long to expect there to not be hair regrowth as well. So when we look at the epilation versus depilation, it's where is the hair removed. So epilation is going to take the hair and the root. So that just tells you, without me telling you, that that's going to be a longer time until that grows back, versus if you just cut something off at the level of the skin, clearly that's going to be something that grows back faster. So things like shaving, trimming, or those chemical depilatory creams, those are all going to be at more of that surface level. Epilation are things like plucking, waxing, sugaring, threading, and epilators. I had to look up the epilator. So that's what I said, and there's always the other things coming out too, and different things. So if your patient refers to something that they are using and you're not familiar with it, it is okay to ask them what it is. It is okay to look up what it is, or if they call it by a different name, then something, that's okay too. You just have to make sure that you find out from them what the process is. So as far as an epilator, if people had not heard of that, that was one that I wasn't as familiar with. It has these these tweezer-like plates or rotating discs or these spring coils that grab the hair as you kind of go up and down the skin, and then it like pulls it out by the root as it's moving. And so if you think about that, any of these sources that are going to be below the surface of the skin, the patients might experience pain associated with them, folliculitis, scarring, and they might have some like post and inflammatory hyperpigmentation. So things are, not without risk associated with that too. So being careful to think about that with the patients, and so like we do with anything, risk versus benefit ratios. Okay, so because back to like the epilators, because like you see those, like I had to look up what they really did, because the way they advertise those on like infomercials and stuff, although I know there's like no commercials anymore, but when there used to be, it was like they had these promises. And so that's why I was like, And so that's why I read about it. I'm like, no, it's just this like fancy tweezer. Like it's not, it's not this permanent removal that they seem to be promising on these like infomercials. So cosmetic, as far as the short term, as I said, that if it's just at the level of the skin surface, you expect that to be something with a more rapid hair growth. Probably the longest thing you get from the surface is going to be the chemical depilatory creams. And then with the epilation, because you're taking the root out to 2 to 4 weeks. Bleaching is not hair removal, but I included it there in that 2 to 4 week category for when the lasting effect of the bleaching. Okay, so is there something anything longer term? The intense pulse light, laser, and electrolysis. And I'll speak to in a subsequent slide why there's a star by electrolysis. It does depend on the color of the hair, the location of the hair, and the amount of hair. So to look at it, this intense pulse light, as it says here, it's this light that has many wavelengths, and then it is absorbed by the melanin in the hair, and the heat from the light interrupts that hair growth cycle. So it's not going to work on, uneven areas, and it's not recommended for patients who develop keloids. So that would be very important in your history taking to, because if patients ask you, you may not obviously be the one doing this kind of therapy, but if they ask you, they're going to go, have this done, what do you know about it, or something like that, like, then you're in your mind, you would want to ask those things. And then it does depend on the color contrast as well. So, it's because it's that it's looking for that melanin. So it's going in that contrast between the skin and the hair. So if it's a darker skin tone with the darker hair, it doesn't work as well. And it's not effective on lighter color hair because it's looking for that darker color hair. So trying to match the hair and the patient's skin tone, for the therapy. So it does require multiple treatments because, from the beginning slides about hair itself being in different phases, not every piece of hair is in the same phase of growth. And then, because it's only going to work on hair that's in the hair growth phase. And so the patients are going to need more treatments, and we're going to talk about laser than with laser. And you can't modify the intensity of the light like they do with the lasers. It could result in burns. Patient reports are that it's more painful than the lasers, and you cannot use them around the eyes. Okay. So next we have, if you've heard of, sort of laser, this too is going to require multiple treatments for the same reason, because hair in different phases of its hair growth cycle. Patients have multiple treatments initially, and then they move into like a maintenance phase of it. It usually doesn't result in permanent hair loss. And of course, you can't use that around the eyes as well. The technology on these has improved so that it has some options for patients with darker skin. It doesn't work for blonde, gray, or white hair because the light is absorbed by the melanin as well. It's still, when you read about it, even though I said like the technology has improved, it's still the contrast is still the lighter skin and the darker hair, and there's less risk of damage to the skin when there's greater contrast, between the two. Okay, so electrolysis, it got the star because it is the only FDA-approved method of permanent hair removal. Thus, my conversation about, advertisements for other things, they may not have the permanency. Now, it will require multiple treatments. It's best for small areas. It can be used on any part of the body. But it is a time-consuming treatment because how they do it is literally into the hair follicle, an electrical current, to destroy that hair follicle. So thinking about how many hair follicles. So that's why thinking about how many treatments it would be, or that's why it's best for, small areas. But the advantage is here with respect to skin color, hair color, skin type, those things, and there's fewer risk and less side effect than the laser. So systemic is what we're going to finish up with today, our medications. And so I'm not going to turn this into like a pharmacology lecture, just a broad overview of the categories of medications. And then, so one of the initial medications that's thought of is oral contraceptives. Now, that of course is not appropriate pharmacotherapy if pregnancy is desired. So, but if it's not, and it's the combination estrogen, progesterone, and we'll talk about that. That's going to be one of the most common initial therapies for patients. Anti-androgens, and this is hugely important, are not recommended as initial therapy unless there's adequate contraception because they're teratogenic. And so, even if patient says that there is no chance that they could become pregnant, even if the patient says they're not sexually active, all of those things, and it's no disrespect to the patient or saying that patients are lying, but you cannot use those unless they're also on contraceptive. So they're usually a next step for the patient. They may be added if the OCPs aren't effective. But like I said, and I will say it again, you must use adequate contraception due to the teratogenic potential and educate the patients about that. And then we'll talk about the topical cream. So obviously, none of these therapies are appropriate if pregnancy is desired. I guess it had additional animation to prove my point. I didn't know. Okay, so the Endocrine Society clinical practice guidelines are here. And so, you can look through those. I had that, like the big guidelines are in the slides too. But when you look at it, if it's the patient important hirsutism despite cosmetic measures is when you would start to think about pharmacologic therapy and for the patient. And then, like I said, a lot of times it would be thinking about it with oral contraceptives as a starting place. And then if desired, talking to the patient about additional sources of direct hair removal to use at the same time as your systemic therapy, or if the patient wants to try systemic therapy first and wait months, and then, add on, those therapies later. Either approach is acceptable if it's mild hirsutism and no evidence of endocrine disorder. And then if you have patients with PCOS, your other treatments for PCOS, if patients are obese, lifestyle changes and things with association with weight loss are really important. So as I said, from a pharmacologic perspective, oral contraceptives are going to be, at the top of our list. If a patient, and this is from their guidelines, they say not sexually active. They do say about anti-androgens. I still would be careful with that because human beings can change their minds. And so I think that, patient education and, making sure that the patient is set up for safety are very important things. So, not using it as monotherapy. And then, but if there's post-sterilization or if the patient has like an IUD, then, that's different as far as using an anti-androgen. So I do have some information in here about the oral contraceptives themselves, but just remembering how long it could possibly take for this to be effective. And then, just a reminder about when selecting an oral contraceptive, and I've read different things about this as far as the progestins, and because there are progestins that have a lower androgenicity, and there's medium, and relatively high. And depending on some different resources, some people, don't seem to think that it matters as much. But, I sometimes think if you have a choice and you're going to do it, then pick one with a lower, type of thing. From that perspective, just err on the side of maybe that's more beneficial to the patient. And some oral contraceptives contain a progestin that's similar to structurally related to spironolactone, which we'll talk about in a moment. So might have some weak anti-androgenic activity associated with it. So they can be very helpful for patients. So like I said, they are equally as effective, but I do tend to veer towards lower androgenicity. Certainly any risk associated with putting a patient on an oral contraceptive is a risk no matter what you're using it for. So if the patient has, a risk of venous thromboembolism or, you can't use these in patients who you can't use oral contraceptives in. So, it doesn't exclude them. Whatever their inherent risk was with it, then this may not be a treatment modality for them. And then that waiting period is necessary to see if it has been helpful for the patient. Anti-androgens, they're listed here. And as I said, you can add them on in a stepwise fashion. And then you're thinking about, spironolactone oftentimes is going to be used. And, it's generally well tolerated, is teratogenic, finasteride, and is used as well. I have listed, flutamide because it's a pure anti-androgen, but it is not recommended because of hepatotoxicity. So topical, if you've heard of this one before, the eflornithine, it does help slow new hair growth. It's not a depilatory. So even though it's a cream, so patients, to not be confused between different types of creams that are out there, it's an adjunct for hair removal. It's costly. Patients have to continue to use it. So it's a maintenance. So it has, cost associated with it. So what's my take home for all of you today is that we have to assess the hirsutism from our perspective as clinicians. We have to be willing to listen and hear about the hirsutism from the patient's perspective. It is our job to determine the underlying cause and then work with the patient based on what the patient's goals are and appropriately address their treatment plan. And that's all I have. Thank you for listening. Questions? No questions. All right. All right. Thanks.